Yeah, just now sharing, sir. Started sharing. Yeah.
இப்ப ஷேர் பண்ண வேண்டாம் ஐயப்பன், இப்ப ஷேர் பண்ண வேண்டாம்.
வேண்டாமா சார்?
வேண்டாம் சார். இப்ப நான் இன்ட்ரோடக்ஷன்.
Okay.
So we can start. Shilpa, we can start.
Just tell me when I have to start sharing, sir. I will start there.
Yeah, I'll tell you.
Good morning and welcome you all for the online anesthesia postgraduate teaching program on Zoom platform sponsored by Akrola and hosted by A1 Logics and simultaneously aired by Anaesthesia TV. Today we are hosting the critical series of the week. Today's topic is on ARDS. So the session will be coordinated by Dr. Rajesh Jayaprakash sir. Over to you, sir.
Sir, good morning, sir, and good morning, one and all. Today in our online teaching anesthesia program in critical care series, we have a very important topic for anesthesiologists, especially those who are practicing in ICU or those who are going in for critical care medicine. The topic is ARDS in a nutshell. So we are going to cover up in 3 sessions. We are going to cover up all basics of ARDS, including the definition, pathophysiology involved in that, and how to diagnose it. Then we have a lecture on how to manage ARDS, both invasive modes of ventilation and non-invasive modes of ventilation. And the next session will be on a recent update about the COVID ARDS. So what is happening with the COVID ARDS? We have 3 eminent speakers today. The first session will be done by Dr. Ayappan, who is a consultant critical care physician from KIMS Health Institute, Trivandrum. Dr. Ayappan is a gold medalist from JIPMER when he did his MD. He did his MD anesthesiology and DNB anesthesiology from JIPMER, Pondicherry. He's a gold medalist from there. And he had done FNB critical care medicine from Bangalore. And right now he is consultant in KIMS Health Institute, Trivandrum. And he has a lot of publications and he's a faculty in many national conferences. And his main area of interest is ARDS management and its ventilator strategies, including prone ventilation. Over to you, Dr. Ayappan. You can start with your session.
Yeah, good morning. Thanks for the kind intro, sir. I'll just share my screen. Can I? Is it visible, sir?
Yes, sir. Yes, sir.
Okay. Sir. My screen is visible?
Yes, sir. Yes, sir.
Okay. Thanks for the kind intro. Without wasting much time, I will go to the topic per se, which is acute respiratory distress syndrome. Okay. So we will have a brief discussion about ARDS, and I will be trying to cover the history, epidemiology, pathophysiology, diagnosis, and the differential diagnosis part of it, and the rest of the management part will be covered by the other speakers. Okay. So what is acute respiratory distress syndrome? It's in a simple terminology, it is nothing but a non-hydrostatic pulmonary edema resulting from hypoxia due to direct or indirect injury to the lung parenchyma. Either a direct or indirect lung injury can result in a non-hydrostatic pulmonary edema, which can result in hypoxemia most commonly, but can also present as type 2 respiratory failure. So before going to the topic per se, I'll just give you a brief clinical scenario of atypical case which we had in our institute before the COVID era. It was a 16-year-old female who presented with breathlessness and a cough with expectoration of a month duration and worsening breathlessness for 15 days. And when she became tachypneic and when dyspnea and exertion worsened, she presented to us. And a CT was done outside, which showed a lung consolidation. Unfortunately, it was done in an outside center, so I don't have the image of it. But when she came, she was hypoxic, but was fairly preserved on the day 1 of admission. And this was the admission X-ray, which typically shows a bilateral middle zone and upper zone consolidation opacity with air bronchograms, typical of a bronchopneumonia. And she continued to worsen post-hospital admission, and day 2, she significantly worsened, requiring invasive mechanical ventilation with lung protective ventilation, of course, and was started on broad-spectrum antibiotics. And it's not atypical to see all of the initial infective workup turning out to be negative. None of the infective workup which I have done turned out to be positive, and she was continued on broad-spectrum antibiotics with supportive lung protective ventilation, and she continued to worsen. And day 3, she required high FiO2 of to a maximum of 100% and was sedated and paralyzed, and was started also on empirical ATT because of the subacute presentation. And on day 4, she developed type 2 respiratory failure and significant subcutaneous emphysema, and it was a tension subcutaneous emphysema, and so bilateral ICDs as well as NICs were placed. So this case, I just gave a prelude just to know the severity of the illness, which can manifest in a young individual presenting to an ICU, and this is the amount of intensive care therapy which they will require, especially in the first week of illness. In the due course of presentation, I will present you what happened to that patient. And so switching to the topic per se, so we will be discussing briefly about the history, definition, causes, epidemiology, pathophysiology, clinical features, and the diagnosis. Coming to the history, so the ARDS as such is not new to medical fraternity or the humankind. Actually, way before in 1821, that is 200 years before, Laennec in a textbook on treatise of diseases of the chest defined it as a pulmonary edema with heart failure, which still holds good and still what we are telling about ARDS. And during the course of the history, it has gone with various names, including wet lung, shock lung, white lung, based on the different clinical pictures which the people noticed. People, when they noticed frothy secretions coming out with bilateral cribs, they named it as wet lung because it was watery, is what they thought. And when they did, when X-ray evolved into the diagnostics, X-ray showed bilateral whiteout, so it was called as white lung. And other than that, it was also called as Da Nang lung. What is it? It is a place in Vietnam. So majority of the medical, including our antibiotics and other therapies, evolved during the wartime. So when Vietnam War was ongoing, this army person who sustained trauma, after an initial period of stabilization, after the first week or during the second week of illness, everyone succumbed to respiratory distress and died because of hypoxemia. So it was named as Da Nang lung. So it went on by various names until in 1967, a landmark paper by Asbach et al. In the American Thoracic Society Journal coined adult respiratory distress syndrome. It was named as adult respiratory distress syndrome to delineate it from infant respiratory distress syndrome, because both of them had a similar radiological feature, but of course the pathophysiology was different. It was because of surfactant deficiency, but it was multifactorial pathogenesis for the adult respiratory distress syndrome. Eventually, because the respiratory distress syndrome which occurred in the adults were also seen in the pediatric population, and it was the name was changed to acute respiratory distress syndrome. How did he define it as? Asbach defined it as a severe dyspnea and tachypnea, which is refractory to supplemental oxygen, and which is associated with the decreased pulmonary compliance and was associated with the diffuse infiltrates on the chest X-ray, which is still the diagnosis or the diagnostic criteria which we use. And these patients on autopsy had a vascular congestion, hemorrhage with fine micro and macro thrombi in the vasculature on the autopsy. But again, the major limitation of it was it did not again differentiate between cardiogenic and non-cardiogenic, because all the above said autopsy as well as the clinical findings can also be seen in cardiogenic pulmonary edema. So then came in 1980 the Murray's definition. The importance of Murray's definition is that till now, even in this century, we use Murray's definition or the Murray's scoring to grade acute lung injury and to refer a patient for a of the Murray score. So it was based on basically 4 parameters. One is hypoxemia. Hypoxemia is based on pulmonary PF ratio and respiratory system compliance, which was the dynamic compliance of the respiratory system, and chest radiographic findings based on the number of quadrants which are involved and with the consolidation, and the level of PEEP, which was the patient was required. So each variable was given a score of 0 to 4, and the final score was attained by the total score divided by the number of components. So the total score will be 0 or 4. When a patient has a score of 0, it indicates there is no lung injury. And when a patient has a score of 1 to 2.5, it indicates mild to moderate lung injury. And there is a score of more than 2.5, severe ARDS. And any patient who has a score of more than 2.5 can be referred to as an indication for referral to ECMO center. And if the score is more than 3, they should be strongly considered for ECMO. So, and again, this was also had its own limitations because pulmonary complaints cannot be routinely measured in all patients. And if a patient is, say, on a face mask oxygen or in the recent trend, a HFNC, it will be very difficult to calculate the pulmonary complaints. And cardiogenic, again, the cardiogenic causes were not ruled out. So these are the limitations. And because of these limitations, and there was non-uniformity of definition of the acute respiratory distress syndrome, and multiple nomenclatures were used, the American European Consensus Conference was held in 1994 with the agenda of developing a diagnostic criteria or definition and a proper therapy or a proper prognostication for ARDS. And they came up with defining definition criteria, which was based on timing of onset, which should be acute, and a radiological finding, which should be bilateral infiltrates on a frontal chest X-ray, and absence of left atrial hypertension or a left ventricular failure, which is indicated by the pulmonary capillary wedge pressure, which is less than 18 mmHg, and hypoxemia, which was defined by PF ratio. So they defined based on these things. The four things which they used were timing of onset, oxygenation, chest radiograph, and absence of left atrial hypertension. So based on these criteria, they differentiated the acute lung injury into two, or the injury into, they named it as acute lung injury. And if a severe form of, or ARDS is a subset of ALI with severe lung injury. So ALI is nothing but acute onset respiratory distress with similar chest radiographic findings and left atrial absence of left atrial hypertension. But the PF ratio will be less than 300, but it will be more than 200. If the same clinical picture is associated with the PF ratio of less than 200, it was called as ARDS. So ARDS was a subset of ALI with significant oxygenation deficit. So what are the limitations? Even though it was a consensus conference and it addressed majority of the issues which were faced earlier, it was not without its limitations. And it was the limitations primarily were the classification itself. It was defined as an acute onset breathlessness, but the acuity was not, or the timeline of the acute was not. It was not mentioned whether it was 7 days or 10 days or 2 weeks. It was never described. And the PF ratio alone cannot be used as an indicator of hypoxemia, because the PF ratio can be variable depending upon the amount of PEEP which you subject to a patient. A patient who is on face mask 5 liters O2, a patient who is on face mask 5 liters O2 with a PF ratio of 200, and a patient who is on invasive mechanical ventilation with a PEEP of 10 and having a PF ratio of 220 or 240 cannot be equated together. Similarly, chest X-ray infiltrates could be because of multiple reasons, and it could be even not only a consolidation, it could be collapse, or it could be any other entity, and it has very less sensitivity and specificity. And PAC in the current era, it is very rarely used, or it is not used at all, and the insertion of PAC itself is associated with significant morbidity and complications. And there was a lot of confusion between the terminology used, whether to term it as ALI or ARDS, and these all led to the correction or addressing these issues was the main priority of Berlin definition 2012. So they addressed whatever the shortcomings of the 1994 definition, and timing, they defined it as less than a week of a known clinical insult or a new or a worsening respiratory symptom. And the chest imaging, again, infiltrates, but it should not be fully explained by effusion, lobar or lung collapse, or nodules. And origin of edema need not require a pulmonary capillary wedge pressure, it can be very well ruled out by objective assessment of the echocardiography, and it does not necessarily mean that there should not be LV failure. It means that LV failure alone should not explain the breathlessness or the infiltrates. It can be coexistent with the ARDS in the sense that a non-cardiogenic non-cardiogenic pulmonary edema or ARDS can coexist with a hydrostatic cardiogenic pulmonary edema. So that is what it meant. And the oxygenation criteria, they eliminated lung injury and they classified ARDS into 3: mild, moderate, and severe. When the PF ratio is between 200 to 300, it is mild, and when it is 300 to 100 to 200, it is moderate, and when it is less than 100, it is severe. And all these PF ratios should be commented only with at least a PEEP of 10, PEEP of 5. Sorry. So they try to address majority of the limitations or the issues with the 1994 AECC definition, but it is also associated with its own shortcomings in the sense that the hemodynamic instability or the vasopressor requirement was not included in the severity of the ARDS. As we all know, if a patient with the ARDS is associated with other organ dysfunction, or if it is associated with sepsis or a inotropic requirement, they carry worse prognosis rather than a single organ involvement with lung, as well as it does not underline any ethiopathological diagnosis, and it has its own limitations in the form that it still uses chest X-ray, which underreports, as well as it the sensitivity of the Berlin definition was also put into question because it missed a lot of patients who were found to have ARDS picture in the biopsy. So these are all the limitations, but now the universally followed guideline is the Berlin guideline, which again uses timing, chest imaging, origin of edema, as well as oxygenation. And based on that, it classifies ARDS into mild, moderate, and severe. ALI, or the acute lung injury terminology, is no longer in use. The pulmonary edema can coexist with ARDS. It doesn't necessarily, it is not an all or none phenomena, or it should be either ARDS or a pulmonary edema. Both can be together, and it should not, the respiratory distress or the breathlessness should not be explained only by the left ventricular failure, and chest opacity should not be explained by effusions or lobar collapse. Okay, so this is the definition and the Berlin definition which is in use. And coming to the causes which most commonly leads to ARDS, it can be broadly classified into direct and indirect. What do you mean by direct causes? Direct causes is the one which causes injury to the alveolar capillary epithelia. So there is a direct injury to the lung parenchyma. So what are all the direct causes? A pneumonia or infection of the lung, and aspiration, near drowning, lung contusion, and inhalational injuries are the most common direct causes which progresses to an ARDS. What are the indirect causes? It is actually, when we discuss about the pathophysiology, we'll be discussing about it in briefly or detail about the pathophysiology, why there is direct and indirect causes for ARDS. Okay, so the indirect causes are polytrauma, most commonly without lung contusion, and massive transfusion, could be sepsis, pancreatitis, cardiopulmonary bypass. All these can indirectly lead to ARDS, because if you look at the alveolar unit, it has a capillary endothelium as well as an alveolar epithelium. So direct causes leads to ARDS by injury to the epithelium, whereas the endothelial injury or the capillary endothelium, which is lining the alveolar epithelium, the injury to it causes the indirect or the indirect causes which leads to ARDS. So there's a pie chart showing the various causes. As you can see, the most common cause of ARDS is or the direct cause of ARDS is pneumonia, followed by aspiration, whereas the most common indirect cause of ARDS is extrapulmonary sepsis, followed by trauma and massive transfusion. Okay, why is it different? Is it essential to differentiate between a direct and indirect cause? Of course, yes, because a direct cause, like an aspiration leading to ARDS, if the inciting event is treated properly and with proper mechanical ventilation, the recovery might be faster, whereas a sepsis-induced ARDS, which is an indirect cause, is associated with worse outcome. So epidemiology, so these are all international data from the lung safe study, which was a large study, observational study done in nearly 4,000 to 4,500 patients, so published in 2016. in which they told the healthcare burden of the ARDS, in which any time in an ICU, around 10% of the patient, that is 1/10 of a patient, will be an ARDS patient, will be admitted in ICU. And if the mechanically ventilated patient is there, among 1/4 or 25% of the patients requiring mechanical ventilation will have an associated ARDS. And this is the healthcare burden the ARDS is associated with. And with the recent pandemic, we know the incidence, importance, and the healthcare cost ARDS can contribute to the country as well as to the whole world. So, coming to the continuing with the epidemiology, again, the severity of illness can also be used as a predictor of mortality. With even though there is recent advances and improvements in the healthcare settings, it is associated with significant mortality, and severe ARDS still contributes to around 30 to 40% of mortality. And the other thing which you have to keep in mind is ARDS is a final common endpoint. It is a syndrome. It is not a single disease per se. And people who die of ARDS die with ARDS rather than die of ARDS. Only 9 to 15% of the patients die because of respiratory failure, and remaining nearly 80% of the patients die because of the primary injury. In the case of sepsis, they die because of sepsis and multi-organ dysfunction. In trauma, they succumb secondary to the trauma-related issues, probably a hemorrhagic shock or massive transfusion-related issues. And majority of the time, people die with ARDS rather than die of ARDS. And the ARDS is a final common endpoint for majority of the diseases. So, with this knowledge about the ARDS, we will discuss about the pathophysiology of the ARDS. Okay. So, pathophysiology, the common inciting event or the initial trigger is either a direct cause or an indirect cause. It can cause either injury to the alveolar epithelium or the capillary endothelium. So, both of which can lead to alveolar injury, which is followed by diffuse alveolar damage. And because of this damage, there is release of inflammatory mediators, especially cytokines, tumor necrosis factor, interleukin-1 and interleukin-6, which is followed by, because of the tissue injury, it is associated with the recruitment of neutrophils and release of its proteases and toxin mediators, which is followed by capillary endothelial damage and flooding of the alveoli with proteinous materials and the movement of the fluid into the alveolar sac as well as the interstitium. So what these things lead to is it leads to increased interstitial fluid as well as alveolar epithelial damage and alveolar fluid, and the alveoli becomes filled with the thick proteinous fluid and cell debris from cell death, and this results in loss of surfactant functioning, and it ultimately leads to alveolar collapse. This is a picture which will may explain better the effects of an ARDS or an inciting event. So here you can see this is the capillary, this is the alveolar epithelium, which is lined by the type 1 pneumocyte, which is the most abundant one, which covers the entire alveolar epithelium. And this is the type 2 cell, which is responsible for the formation of surfactant. And this is the alveolar membrane, basement membrane. And this is followed by the capillary endothelium with its capillary endothelium. So in direct injury, what you have is there is injury to this alveolar epithelium, which causes, usually these type 2 cells are resistant to the injury. Only the type 1 cells will be injured, and that is followed by cell death, apoptosis and necrosis of these cells, which results in the cellular debris getting accumulated here. So this results in the activation of inflammatory cascade and release of inflammatory mediators. Okay, so this is the pathogenesis of the inciting event in a direct cause. Whereas in an indirect cause, what happens is because of a systemic illness, say a sepsis or a massive transfusion or a trauma-related endothelial injury, there is injury to the endothelium, which results in escape of the neutrophils through the endothelial injury, which recruits neutrophil-related proteases, macrophages, as well as inflammatory mediators. And these leaky capillaries, or the leakage or the increase in the capillary permeability, releases the proteinaceous plasma into the interstitial fluid. And once the epithelial cells are also injured, these fluid or the plasmin or the protein-rich plasma floods the alveoli along with the dead type 1 cells, resulting in cellular debris, alveolar sac being filled with proteinaceous material as well as the inflammatory cells. The type 2 cell, which is resistant to injury, continues to function, but it will be injured and it will function suboptimally. But the surfactant, which is released here, will not be forming an effective coat like how it has done here. So you will have loss of surfactant, which results in increased surface tension. The surfactant is the one which reduces the surface tension of the alveoli, which prevents the alveolar collapse during normal ventilation. When this surfactant layer is lost and it becomes inactivated surfactant, which floats in this fluid, the surfactant is lost, or the function of the surfactant is not there, which results in alveolar collapse. Okay, so an alveoli which was like this ends up like this. It could be secondary to a direct injury to the epithelium, or could be an indirect injury to the endothelium. So, this is the damage which happens, and this is what it looks like. Okay, so the other thing which happens is whenever there is endothelial injury, as we all know, it is associated with activation of the coagulation cascade. So there is increased procoagulant activity and impaired fibrinolysis, both leading to both intravascular and extravascular microthrombi formation. Because of the tissue injury, there is increase in the tissue factor expression, and there is increased plasminogen activator inhibitor. In other words, there is decreased fibrinolysis and increased coagulation, resulting in thrombi formation. So what does this all lead to? All of this leads to a impaired gas exchange or a hypoxemia, which is resistant to increasing FiO2, and a decreased lung compliance and pulmonary hypertension. Why there is refractory hypoxemia? As we told in the picture, we have increased alveolar exudates, which prevents the gas exchange from happening. There is an alveolar collapse, which creates a shunt, because the perfused segments will not perfused segments will not contribute to the gas exchange because the alveoli is collapsed. There is widened alveolar septum, as we saw, because of the increased interstitial fluid, and all of these leads to V/Q mismatch and pulmonary hypertension, and in turn these leads to refractory hypoxemia, which means even if you increase the FiO2, there won't be increase in saturation. Okay, the obvious reason of the other thing is the pulmonary hypertension. Why there is pulmonary hypertension? The pulmonary hypertension happens secondary to altered vasomotor tone. Why does that happen? Whenever there is hypoxemia, the physiological phenomenon of hypoxic pulmonary vasoconstriction steps in, causes constriction of the non-ventilated capillaries, resulting in increased pulmonary pressures. There might be associated hypercarbia because of increased dead space, which can result in again pulmonary increase in the pulmonary pressures. And there is, because of the injury, resultant increase in endothelin and thromboxane A2, which can also contribute. And as we told earlier, because of the coagulation cascade activation, it can cause microthrombi in the pulmonary vasculature, resulting in again increased physiological dead space. All these, if it is very significant, along with this, we will have started them on lung protective ventilation with high PEEP. High PEEP will also contribute to an increase in the pulmonary artery pressure by causing over distension, might sometimes cause over distension. So all these will lead to pulmonary hypertension. If it is in a severe form, can cause acute respiratory failure. And if the pulmonary pressures are so high, which causes acute respiratory failure, so that the pulmonary, to an extent that the pulmonary pressure becomes more than the right heart pressure becomes more than the left heart pressure, you can cause incidental opening of an previously patent foramen ovale. So the alveoli, which was normally functioning after the injury, ends up like this. So this is during the proliferative phase, where you have the type 2 pneumocytes, or the type 2 cells, which has proliferated to cover up for the type 1 cells which are injured. And there are aquaporins and water channels which have developed to remove the fluid, and there are fibroblasts and other myofibroblasts and the collagen deposition happening here, and there is apoptosis of this debris material. And this is the proliferative phase where the exudates which were there will be actively cleared from it. And some of these patients during the course of the therapy may go into a next phase called as the fibrotic phase. The presence of, now it is termed as fibroproliferative phase, because as you see in the timeline, this is the exudative phase, which happens initially. It starts with the injury, it goes up, and the exudative phase tends to end by around the 4th to 7th day of illness, whereas your fibrotic or the proliferative phase or the fibrotic phase starts in the first week, peaks it around the second week. It is the proliferative phase from the 7th to 14th day, and predominantly fibrotic phase after that. Not every patient who has ARDS will progress to fibrotic phase, but the people who progress to fibrotic phase can have sequelae in the form of fibrosis and cavitative lesions. So clinical features, the clinical features usually symptoms will be, as I told, it will be breathlessness, cough, fever with expectoration and fatigue, which worsens over a period of time. And based on the etiology, it can differ. Okay. If it is a hospitalized patient with sepsis, it's an extrapulmonary sepsis, they would have admitted with this different complaint, but eventually will develop breathlessness during the hospital admission. So initial 24 to 48 hours will be secondary to the inciting event. If it is pneumonia, it will be pulmonary symptoms. If it is extrapulmonary, it will be the extrapulmonary symptoms which will manifest. But once the common endpoint of ARDS is reached, it will be predominantly the respiratory distress associated with hypoxemia with increasing oxygen requirement. And if not treated appropriately, it can lead to neurohypoxia, resulting in agitation, anxiety, and confusion. So these are all the clinical findings, and the signs will be the same: bilateral cribs. So these things we all know. And if you do ABG, it will show increased AA gradient. Right? The typical feature is refractory hypoxemia. So coming to the differential diagnosis, there are a lot of ARDS mimics. The most common mimic is, of course, which we are trying to differentiate, which is the congestive heart failure, which you all know how to rule it out, because there might be elevated GVP, peripheral edema, or could be signs of left heart failure in a clinical examination or in an echocardiography. And it could be a COPD or asthma, but COPD and asthma most commonly will present with other clinical symptoms like which responds to steroids, will have a chronic course, and they would have had previous episodes of admission with similar episodes, and they predominantly will have type 2 respiratory failure. And pulmonary embolism can be ruled out. It will be out of proportion hypoxia with a normal imaging finding of the X-ray. And acute eosinophilic pneumonia, hypersensitivity pneumonitis, and the pulmonary alveolar proteinosis, all these can have similar radiological feature like an ARDS, but performance of bronchoscopy followed by a BAL, or a subject of these patients to steroid will show tremendous improvement, and in that way it can be differentiated. And pneumothorax and sepsis is a clinical diagnosis which can be differentiated. So this is the cardiogenic pulmonary edema. This is the ARDS, as we know. The typical X-ray differences, which will be highlighted here. Your heart size might be normal in a ARDS, whereas it will be increased or can also be normal in cardiogenic pulmonary edema. Kerley's B lines can be there. Associated pleural effusion can be there. And it will be predominantly perihilar with the peripheral sparing, whereas it will not be like that in a non-cardiogenic pulmonary edema, and as well as septal lines will be increased in a cardiogenic pulmonary edema. So based on these pathophysiology, as we were saying earlier, as I was saying earlier, the X-ray is a poor modality. Based on the X-ray, it was always thought that it was a homogeneous infiltrates, or the bilateral similar infiltrates on the chest X-ray. That is what it was thought initially. But with the advent of the CT and the universal subjection of these patients to CT, gadolinium and antimonium found that it is not a homogeneous involvement and it is a heterogeneous involvement. And the lungs, predominantly the involvement is restricted to the posterior as well as the basal component, and the anterior and the apical components are majority of the time preserved, and it is a non-homogeneous involvement of the lung. And this will lead to the concept something called as baby lung, where you are ventilating actually a functionally small lung rather than an anatomical small lung. And this led to the miraculous improvement of the management of these patients, and which will not be, I will not be discussing in detail about this, which will be in the further slides by the further speakers. So based on this, the management can both the other thing which I want to stress is the management is predominantly supportive, treating the inciting event, and the management can be either ventilatory or non-ventilatory, which will be by the subsequent speakers. And going back to the case scenario, this patient after the 7th day, she developed bilateral subcutaneous emphysema with the type 2 respiratory failure with the tension subcutaneous emphysema causing an extrapulmonary restrictive lung disease. So the NICs were done to drain the subcutaneous emphysema, which transiently removed or improved the ventilation. And she was continued on lung protective ventilation. And slowly with supportive therapy and positive pressure ventilation. This is the serial ABG, which shows a gradual improvement with improvement of PF ratio to 258 on day 7 of illness. And the typical during the typical course, she developed because of the antibiotics, sedation, paralysis, as well as steroids for the hemodynamic instability. She had significant neuromuscular weakness, so had difficulty in weaning, had to undergo tracheostomy for the same. And it was a critical illness polyneuropathy, which was treated supportively with high protein diet and other supplemental measures. And she also developed a VAP in the course of the therapy, which was treated with high-end antibiotics. And on the 3rd week of illness, she recovered from the disease. And by the 4th week, she was discharged. And this was a discharge chest X-ray. And this was the CT, which was done at 3 months after the follow-up. So the thing I want to highlight here is if the resource which is required here is very high, and it will be a stormy first 7 to 10 days. And if they are supported appropriately, preventing further injury to the lung, majority of the patient can be salvaged. And it is these young patients who present with viral pneumonia with ARDS. If we treat appropriately, they tend to have a very good quality of life, and they have very limited long-term sequelae. The sequelae will be predominantly related to the neurocognitive and the neuropsychiatric issues rather than because of the pulmonary sequelae. Thank you. Thank you once again for the opportunity.
Thank you, Ayappan, for the nice, excellent lecture. You know, it's a very last minute call. You have done a beautiful job on highlighting the things about the ARDS diagnosis and the pathophysiology. And the way of you explained the pathophysiology was excellent. And there are a lot of new things which we have gained from your presentation. So I have small doubts, Ayappan. Number one is how much lung ultrasound is helpful in diagnosing ARDS?
Yes, sir. Actually, it should have been a part of the discussion. Actually, so previously it was the. Am I audible, sir?
Yeah, you are audible.
Yeah. So the previously we tend to rely more on chest X-rays. Now with the advent of ultrasound, we tend to perform lung ultrasound more, and majority of the patients will not be in a condition to be shifted to CT. So there are certain various ultrasound findings, like both of the ARDS as well as the cardiogenic pulmonary edema will have similar B-line profile, but it will be more uniform in cardiogenic pulmonary edema, whereas it will not be that uniform in ARDS. And there will be pleural-based septal thickening as well as pleural irregularities, which will be seen in a ARDS, whereas those things will not be seen in a cardiogenic pulmonary edema. Other thing is underlying effusions, and as we all know, ultrasound is on par with CT for diagnosing effusions, and you will have bilateral effusions, which will be more like a transudate when you have a cardiogenic pulmonary edema. Even your ARDS can have effusion. Most of the time it can be unilateral with the underlying consolidation, or most of the time it can be exudative, which can be diagnosed by the internal echoes and the floating echoes which we see in that. So ultrasound is a valuable tool which can definitely delineate between cardiogenic as well as non-cardiogenic causes of ARDS.
These are also common doubts among the postgraduates. Does antibiotics have any role in ARDS management?
Sir, hello.
Antibiotics. Does change of antibiotics, or is there any specific protocol to select antibiotics in ARDS management?
It depends. If it is ARDS, it is based on the etiology which you are looking at. So if it is a community acquired pneumonia, majority, if you think it is bacterial pneumonia, the general antibiotic protocol which we start is a beta-lactam antibiotic with a atypical cover with either azithromycin or doxycycline. In the sense, a macrolide with a macrolide or a tetracycline, doxycycline to cover atypical antibiotic. And if it is a endemic country, endemic place for viral infection, say a seasonal variation of influenza is there, then we can consider antiviral with oseltamivir. If it is a COVID, then obviously we know how to treat the COVID. So the general antibiotic pattern is a beta-lactam with a atypical cover with a macrolide or fluoroquinolone. But in Indian context, we tend to avoid use of fluoroquinolone because of the incidence of TB in our community. So this is the general practice. If there is risk factor for resistant infection, or if the patient has risk factors for pseudomonal coverage, then we have to go for anti-pseudomonal cover with probably atypical cover. So this is based on a case-to-case scenario, and ARDS patients invariably will be treated with antibiotics and antivirals as well.
Depending upon the pathophysiology, what you have explained, is there any role for furosemide in treating ARDS?
No, sir. Actually, there is a large trial which was done based on the same ARDS group has done a trial in ARDS patients. There is no role of empirical steroids, but a fluid conservative strategy is preferred over a liberal fluid strategy. So the general practice is to try to maintain a slight negative balance or a neutral balance rather than giving a lot of fluids in case of hemodynamic instability. In other words, instead of bombarding them with the fluids, go for a low dose vasopressor support to maintain the hemodynamics and try to maintain a net neutral balance or a slightly negative balance rather than if needed, we can use diuretics, but not on a routine basis.
So what is the role of steroids in ARDS? Which phase of steroids, which phase of ARDS will have good effect with steroids, and where we should not use steroids? What is the current practice?
So the current practice is actually that previously, before the advent of COVID, actually the recommendation was to use steroids within the first week of illness. If you are using steroids, use it early. Don't use steroids in the third week of illness. And if you are using in the second week, it is a risk-benefit analysis based on that you can use. And the previous recommendation was strictly avoid steroids in viral pneumonias. Viral pneumonia related ARDS, especially if you are suspecting influenza pneumonia, avoid steroids because it is associated with increased viral shedding and prolonged illness. But with the advent of COVID, it has changed the entire practice. Now steroids are used very commonly, but as per evidence, if you have to use steroids for non-COVID ARDS, use it only in the first week of illness. Don't use it in the third week of illness where they are more prone to develop secondary bacterial infection. Avoid steroids in the third week of illness. When you don't know the duration of the illness, it is a case-to-base analysis whether to use steroids in the second week. Generally, if it is refractory hypoxemia, you go for steroids. Otherwise, no role of empirical or routine steroids.
One last question.
Yes.
You want to? Depending upon the pathophysiology, what you have explained, the one common management in ARDS is prone positioning. So when to go for prone position? It should be early or late proning. Should we wait for some criteria to select the prone?
No, sir. Yes. Previously, prone was considered as a salvage therapy like your ECMO. But no, prone is no longer a salvage therapy. It's a standard of care. Prone is a standard of care. You put them on ventilator if you started them on invasive ventilation. Invasive ventilation, you show a PF, you see a PF ratio of less than 150, and you repeat an ABG after say 2 hours, and if the PF ratio is decreasing in spite of your lung protective and optimal PEEP strategy, go for early proning. Early proning, now the recommendation is to go for prolonged proning for at least 16 to 18 hours per day, which can even be extended up to 24 to 30 hours depending on the institute policy. So prone is no longer a salvage therapy, and it should be done earlier. And the extra pulmonary causes of ARDS, say a trauma-related ARDS or a trolley-related ARDS, they respond very well to your proning compared to your localized pneumonia-related ARDS.
Thank you, Evan. Sir, Edward sir, do you have any questions, sir?
Sir, very nice discussion, sir.
Now, do you have any questions to ask?
Move on to next topic.
Okay, thank you, Evan. Thanks a lot for your nice presentation, Evan. We will move on to the next session. The next session will be on both invasive and non-invasive modes of ARDS management by Dr. Lakshmikant Charan, who is a consultant intensivist from Royal Institute of Royal Care Medicine, Institute of Critical Care Medicine, Royal Care Super Specialty Hospital, Coimbatore. We welcome you here, sir, Charan sir, for your session on ventilatory management in ARDS. Over to you, sir.
Am I audible, sir?
Yes, sir. Yes, sir.
Is my screen visible, sir?
Yes, sir. Screen visible, sir. You can start your session, sir. Thank you.
Yes. Thank you. Thank you for your introduction, sir. I think the previous speaker, Dr. Ayyappan, gave a very good overview on the etiology and pathogenesis of ARDS. Without knowing all those things, it is very difficult for us to understand how to ventilate these patients. So he has made it easy for me to go ahead with the management of these patients. I would like to start my talk by acknowledging my teacher, Dr. Ranvi Rajagopalan, who taught me everything in critical care, my chief, Dr. Shivakumar, who is for his continuous career guidance, and Dr. Rajesh, Dr. Edward, and the other organizing team in the online anesthesia critical care series team for giving me this opportunity. So the objective of my talk in the next half an hour is predominantly going to be the alteration in physiology, what happens in ARDS, which was already dealt with by Dr. Ayyappan. I'll just give you a small gist. The differences in flow and airway pressures due to this altered physiology. And based on these altered physiology, what are the consequences for the changes in the flow and pressure? And what are the challenges that we face in ventilating them when compared to ventilating the patients, other patients? And how do we successfully ventilate facing these challenges and also to minimize the problems? And what are the non-ventilatory strategies that are useful in ARDS? My talk I will base it predominantly on the whatever evidence that we have now, and also based on what I practice or what we practice or most intensivists practice in current scenario. So some of the basic things that I want you to be clear before going into this ventilatory management of ARDS is the pressures, flow, and volume that we need to know in the lungs and ventilation. Ventilator, as we all know, is a machine which generates pressure necessary to cause a flow of gas that increases the volume in lungs. So the basic thing that we need to do is to put tidal volume into the lungs, into the alveoli, so that the oxygen that is there in the tidal volume in the alveoli gets diffused into the alveolar membrane, into the arterial membrane, and gets oxygenating the blood. So that is the basic aim for us to do. For that, we need the flow of air into the alveoli. And for that flow of air to happen, we need some amount of pressure that is being generated. As we all know, in spontaneous ventilation, we generate that pressure as a negative pressure by the contraction of your diaphragm and the inspiratory muscles, which creates an inspiratory negative pressure in your intrathoracic cavity, thereby sucking in air from the atmosphere into the lungs. Whereas in a ventilator or in a mechanically ventilated patient, what happens is this pressure is generated by the machine, and it generates a positive pressure outside the patient, and that pushes in the air into the alveoli. So for this pressure being generated by the ventilator and the flow of air causing an increase in the volume in the lungs, there are a lot of parameters which influence them, and it all depends on the pathology of the lung which is being ventilated and the amount of damage that the lung has had. So there are two basic things, that is the resistance and the compliance in the respiratory system, which are very important for us to ventilate a patient. Resistance predominantly, as we all know, it is the factor of your airway, right from your trachea to the distal bronchioles. And compliance, as we all know, it is predominantly that of your alveoli or the air sacs, which is the most important part where the exchange of oxygen takes place. So resistance and compliance together is very important for the respiratory system to act normally and for the ventilation to happen properly. Whenever there is an increase in resistance or a decrease in compliance, there is an increase in the work of breathing. Even if it is a spontaneously breathing patient, whenever there is an increase in the resistance because of a wheeze or a bronchospasm, or whenever there is a decrease in the compliance, there is definitely going to be an increased work of breathing, and that is the reason why the patient comes to the hospital or to the ICU when they become dyspneic, tachypneic, and they are not able to maintain the necessary work to maintain oxygenation of the body. And that is the main reason why most of these patients get into the ventilator. We need to reduce the respiratory fatigue, and when they get into respiratory failure, we go in and intubate the patient, ventilate the patient to take over that work of breathing. So this ARDS, as Dr. Ayyappan already said, is predominantly a problem of compliance rather than the resistance. So the problem is predominantly in your lungs, in the alveolar level, where compliance, as we all know, it is nothing but the change in volume to the change in pressure. So how much pressure is needed for the tidal volume to be generated in the alveoli? If the same amount of tidal volume starts requiring more and more of pressure, it means the patient's lung compliance is slowly coming down. If the same amount of tidal volume is being attained with a less amount of pressure, it means the compliance of the patient or the compliance of the lung is improving. So basically, whenever there is a decrease in compliance, you need more pressure to deliver the same amount of tidal volume. And that is what basically happens in the ARDS or many of our type 1 respiratory failures. And what we need to do in this ventilation or in the management of ARDS is to tackle this problem rather than the problem with your resistance. So mechanical ventilation, it offloads the work of the respiratory muscles, as well as we need to do certain things to manage this compliance problems. So in this pressure, there are two different types of pressure. As we all know, it is your peak respiratory pressure and your plateau pressure. This is, I presume that you are to a certain extent good with your ventilator graphics. This is a volume controlled ventilation. This is a pressure time scalar. And as you can see, this is your positive end expiratory pressure. This is the pressure, which is the positive pressure that we maintain at the end of expiration. Your lung doesn't collapse completely. It maintains at a slightly higher pressure, which is your peak. And from that peak, whenever the patient starts inspiring or whenever the ventilator starts giving an inspiratory tidal volume, your pressure slowly rises up and it reaches the maximum. That is your peak inspiratory pressure. It depends on the tidal volume that you set, depends on the patient's lung. So after the peak pressure is reached, what happens is the expiration starts and your pressure starts coming down. But this peak pressure is not the only pressure that is important for us. The most important pressure is your plateau pressure. To know the plateau pressure, what we do is we give a pause at the end of inspiration. That is, we interrupt or pause the flow of air into the lungs and out of the lungs. So there is nil flow in the respiratory system. And when there is no flow, what happens is the pressure at the level of the distal alveoli, that is the distalmost part of your respiratory system, gets equated to the proximal airways, and that is being measured in the ventilator as your plateau pressure. But predominantly, when you don't give this pause, what is the pressure being measured is your peak inspiratory pressure. That is the pressure at the level of your proximal airways, that is your trachea, bronchus, and the distal bronchioles, which is not very important for us. This doesn't cause a major problem to the patient, even if the peak pressure goes up to 60 or 70 or 80. The patient doesn't get into a major problem. What is important is the pressure at the level of the alveoli. As Dr. Ipan mentioned earlier, in the areas alveolar level, the alveolar epithelial membranes are always already being damaged. The basement membrane is being damaged. Already injured basement membrane and the alveolar epithelium. When this pressure at the level of alveolus goes high and high, what happens that alveoli gives away or the amount of ARDS increases. So always whenever you ventilate a patient, what is more important for us is the plateau pressure and not the peak inspiratory pressure. Give a inspiratory pause, measure the plateau pressure and see to that the plateau pressure doesn't go high. So this is your peak, this is the peak inspiratory pressure, this is the plateau pressure, and the level of pressure above the peak to the plateau pressure is what we call as the driving pressure. That is the pressure needed for us to deliver the AF. So why is it important? In the baseline, as we all know, peak pressures are high, followed by the plateau pressure. Whenever there is a problem with your resistance, as a patient with bronchial asthma or other resistive lung disease, what happens is the peak pressure goes high, but your plateau pressure remains the same. There is no issue with your plateau pressure, only your peak pressure goes high. You give nebulizers or other treatments for the bronchoconstriction. This peak pressure comes down. It is not an emergency. It is not a very severe condition. But what happens is in a patient with a decreased complex, such as in an ARDS, there is an increase in the peak pressure as well as your plateau pressure. Though the peak pressure, plateau pressure gradient almost remains the same as a normal patient because the peak pressure increases as a result of the increase in the plateau pressure. This is what is very important for us. Whenever there is a complex problem, plateau pressure slowly goes up and up. It reaches a state where it can cause injury to the alveoli, it can worsen your ARDS, it can cause barotrauma or a rupture of your alveoli and a removal. So this is what is very important. Always see for the increase in your plateau pressure whenever you ventilate a patient. So it need not be a patient with ARDS. Any patient you ventilate, keep monitoring your plateau pressure. Whenever the plateau pressure goes high for the same amount of tidal volume, always think there is some problem with your complex. So coming to the ventilatory management of ARDS. So what are the goals of management of ARDS? As I already mentioned, the most important goal for any patient in the ARDS is to treat the primary cause. It can be a direct pulmonary cause or extra pulmonary cause of ARDS, whatever it is. Only when you start treating the primary cause and only when the primary cause is treated, the ARDS improves. If primary cause is a pancreatitis has to improve for the ARDS to improve. If it is because of the trauma itself has to improve for it to improve. If it is a pulmonary cause, it can be a pneumonia. Only when the pneumonia is being treated and it improves with the antibiotics, your ARDS will improve. Just ventilatory management will not improve ARDS. So what do we do with the ventilatory management? Predominantly, ARDS is a compliance problem, and because of the compliance problem, you have problem with your oxygenation. So it is a hypoxic respiratory failure. What we try to do is improve the oxygenation in this patient by ventilating them. But in the meal process, as we all know in medical fraternity, the first thing that we learn is we primum non nocere, or we do not harm a patient. Even though you don't do something good for the patient, always try to not harm the patient. So whatever management or whatever drug or whatever treatment you do, there are some side effects. If the side effects are more, please do not use it. So what are the side effects with the mechanical ventilation that we need to be very, very careful for us to avoid them is ventilator-induced lung injury. So the third most important goal of your ARDS ventilatory management is to avoid this ventilator-induced lung injury. What is this ventilator-induced lung injury? This ventilator on by mechanically ventilating the patient can cause polytrauma, atelectrauma, biotrauma, and barotrauma. As we know, polytrauma is nothing but lung being not homogeneous, ARDS being a non-homogeneous disease. There are some part of the lung which are good and some part of the lung which are bad, but whatever volume we give goes to both the parts of the lungs, and because of this, there is over distension of the normal alveolar units, and it can cause problem with that normal. Barotrauma is nothing but an increase in the total transpulmonary pressure, as we saw earlier. Our main aim is to generate a tidal volume by generating a pressure. So the amount of Volume generated depends on the amount of pressure. When you want to generate more volume, you need to give more pressure. Whenever the pressure increases beyond a point and cause disruption of the basement membranes at the level of the alveolar epithelium. This is again is very, very important. Biotrauma, as we saw, as it was mentioned earlier, ARDS is a problem of an inflammatory response system, and it causes release of chemokines and cytokines as it was recently in COVID pandemic, it was called a cytokine storm. This cytokine release can worsen the progress of ARDS. So every time you ventilate a patient with ARDS, more and more ventilation and more lung non-protective ventilation can cause more release of cytokine and worsening of the basic problem as well. The next thing is your atelectrauma. As we all know, the lung completely collapses at the end of ventilation in these ARDS patients. And every time it completely collapses, there is more amount of work needed to open up this lung, and the more amount of work is needed to keep the lung open at the end of expiration. And if it comes, the repeated alveolar collapse and expansion with the tidal volume will definitely cause further injury, and it can contribute to further lung injuries. Next is a shearing injury between a collapsed lung and the lung that is being participating in the, and the oxygen toxicity. As we all know, if you are going to give high level of oxygen for a long period of time, can cause injury to the cells because of the free radicals that is being generated. So all these things are the ventilator-induced lung injury that can happen when you mechanically ventilate this patient. For our primary goal of maintaining oxygenation, we should not cause further harm to the patient. So maintain oxygenation by avoiding all these ventilator-induced lung injury will be our prime aim in this ventilation. So as it was mentioned earlier in the pathogenesis, what happens in ARDS? It is a syndrome of inflammation. This is your alveolar level. This is your capillary endothelium. There is a diffuse alveolar epithelial damage as well as breakdown of the endothelial barrier. Once the endothelial barrier breaks through, what happens? There is leakage of fluid from the endothelium, capillary endothelium into the interstitial space. There is more and more amount of interstitial edema or the pulmonary edema. What happens when this diffuse alveolar epithelial damage increases as a part of this ARDS? This fluid enters into your alveolus. So the alveolus gets flooded. Most of the alveoli gets flooded with the fluid, and those alveoli cannot take part in the oxygenation process. When it is filled with fluid, the oxygen cannot come to this alveolar epithelial level for it to get transferred into your capillary. So more and more amount of lung getting flooded with the fluid, and more amount of lung that is being affected by ARDS, the more is your oxygenation problem. So it was found in the early ARDS management protocols. It was seen in the CT clearly that when a patient with ARDS has a CT, there is predominantly posterior or the dorsal portion of the lung which has a collapse. These lungs units completely collapse, and it is difficult for us to open up these lung units. And in the anterior or the ventral portion of the lung, there is some amount of lung which is spared, and there is preservation of the normal lung units in this anterior part. And in between, there are varying degrees of pulmonary edema, what we saw earlier as the alveolar swelling, which happens at varying degree in the intermediate lung units. So it is definitely a non-homogeneous or a heterogeneous disease. It doesn't affect the lung uniformly. Lung is not only stiff but also small. It is as small as a baby lung. The amount of normal lung that is being ventilated is very small. It is almost equal to a baby's lung of a 6 or 7-year-old child. And when you ventilate it with the normal tidal volume that is required for an adult, what happens is this baby lung is not able to tolerate that part. So basically the lung has a normal aerated segment which inflate easily and even with a low pressure and tidal volume. These are always called as a fast alveoli. They need very low pressure to open up, and they get aerated better. In between, there are partially aerated segments, and the posteriorly predominantly there are unaerated segments which distend very poorly and needs very high pressure for us to open up these alveoli, and it shows a slow response. Because of these heterogeneous mixture, the tidal volume that we need to give to the patient needs to be very, very careful. As it was again mentioned earlier, the normal alveoli, when you give it the tidal volume, it gets distributed equally to all the alveoli. Whereas in the ARDS baby lung, when you give a tidal volume, what happens is predominantly goes to the normal alveoli, because most of the alveoli which are fluid filled or fluid flooded will not take up any amount of tidal volume or oxygen, and the atelectatic alveoli, which is already collapsed, needs more work or more pressure for us to open this alveoli. So only a little of the air or the tidal volume goes into this collapsed segment. Predominant of the air or the tidal volume goes to the normal alveoli. What happens in normal alveoli? It takes the distance enormously, and there is over distension of the normal alveoli, and it needs to be handled very gently. So this is the pressure volume curve, which we usually speak about when we talk about the complaints or problem in a lung. This is your normal pressure volume curve. What we call it as it is a hysteresis. That is, there is a part of the waveform where this is your inspiratory wave part of the waveform, and this is your expiratory part of waveform. It doesn't. It is not equal, because at any pressure level, there is always more amount of tidal volume in the lung that is expiring than in the lung that is inspiring. So there is always a difference in the tidal volume. That is the reason why these two are not same. And during inspiration, it goes like this, and during expiration, it comes down like this. This is the pressure volume, the relationship of the tidal volume to the pressure that is being generated in the lung. If this is your normal hysteresis or the pressure volume curve, what happens in the area? As we saw earlier, the compliance decreases. Because of the decrease in compliance, you need more pressure to generate the same amount of tidal volume. So this pushes the curve to the right side. So this is how your pressure volume curve will be in a patient with a compliance problem or an ARDS. So what happens is, the lower part of the curve is predominantly a collapsed lung, and the upper part of the curve, what happens, it is a over distended or the normal lung which is getting over distended, and it can cause rupture of these alveoli. And in the lower part of the curve, this is your collapsed lung, which doesn't take much of the tidal volume that is going to the lung. So this amount of polytrauma was evidently proven by Gattinoni et al. In a study that was done in 2001, when they started doing CT scans for all the patients with ARDS. In the patients who got recovered from ARDS, they found that there was a lot of anterior lobe reticular pattern, and some of them even had a non-dependent bullae. This means that there is some amount of polytrauma that has happened to this anterior or the ventral portion of the lung, which predominantly will be a normal lung in an ARDS. Mostly in ARDS, the dorsal or the posterior lung will be affected, and the ventral or the anterior part of the lung will be normal. And these ventral parts started showing signs of having had a polytrauma during the period of operation. So it was very important for us to know this and to avoid this complication. The next important complication is your barotrauma. As we saw earlier, plateau pressures are very, very important. When the plateau pressure exceeds a limit that is set as 30 centimeters of water, it is just an arbitrary number out of the multiple studies or evidences that we had in ARDS and normal population before. It doesn't mean that if 28 is very good and 32 is very bad. We just take it as a number of 30, and we try to control the plateau pressure less than 30. The lower the pressures, better the outcome. Plateau pressure is the most predictive value for lung injury. Always try to keep it low. Decrease alveolar over distension, and it reduces the risk of lung strain. So you need to adjust the tidal volume also to ensure plateau pressure. As we saw earlier in the mechanical ventilator, the pressure is being generated to maintain a tidal volume. So whenever you want to control the pressure, you also need to salvage some amount of tidal volume. You need to come down on the tidal volume. There are some patient groups in whom you can have a certain permissible increase in the plateau pressure. That is the group of patients like patients who are very obese, pregnant patients, or patients with a large ascites. They have a large abdomen pushing the diaphragm up, and that causes some amount of increase in the pressure in the lung. So to compensate that pressure, you can have a slightly higher plateau pressure in these patients like 32 or 33. It won't cause a major problem to the lung in these patients. So that brings us to the concept of lung protective ventilation. As we saw earlier, polytrauma has to be prevented by reducing the tidal volume. Barotrauma has to be prevented by reducing the plateau pressures. And both these things together comprise the lung protective ventilation. So before ventilation, is there anything that we can do? We know that ventilation is causing a problem of ventilator in this community, whether it can be avoided. So there are a lot of interest in non-invasive ventilation, as you all know. Now in almost all the small setups, they started using the non-invasive ventilator, and it is being used in the ward and even in the step-down areas. So there has always been a interest in non-invasive ventilation usage in ARDS, and it was increased after a small RCT that was published in somewhere in 2000s, when it was compared with venturi mask, and it showed an improved oxygenation and a lower rates of intubation. But later, in a large study in 2016, in a lung safe study, there was a subset analysis that was made, and it was clearly proven that non-invasive ventilation in severe ARDS is an independent predictor for mortality. So in severe ARDS, do not use a non-invasive ventilator. There were further subset analysis, and in a prospective study in 3,306 patients, it was found that in a specific group of patients, that is, in a patient who had a pulmonary etiology, they showed a slower improvement and more NIV failure and more mortality than extrapulmonary etiology. That means that in extrapulmonary etiology of ARDS, you can still try non-invasive ventilator, but with caution. If at all you're going to use non-invasive ventilation, it has to be reserved to occasional patients with mild ARDS. They should be hemodynamically stable, easily oxygenated, and does not need an immediate intubation, and no contraindications for its use, such as low GCS or chances of aspiration. As we all know, non-invasive ventilator has a grade 1 or the absolute indication only for type 2 respiratory failure, where there is a hypercapnia in patients such as in COPD. In type 1 respiratory or hypoxic failure, it is not being recommended, and it is only used out of our own interest. So if you ask us what we do, we use it with caution for selected individuals with mild ARDS under close supervision, only in ICU. Never use these NIV in a patient with evolving ARDS in the ward or in the place where there is not much of a monitoring. And if at all there is a doubt, intubate them immediately. Do not prolong the non-invasive ventilation when you have doubt that the patient is not improving. So having ventilated the patient, the first thing that we do is connect it to the ventilator. The first thing that we need to select is the mode of ventilation. So which mode is better for the ARDS? We always have two specific modes based on which all the newer modes are made. It is either a volume cycle or a pressure control. In a volume cycle mode, you can guarantee your tidal volume, you can prevent volume trauma, but the problem is airway pressures are not controlled, and still patients' pressure can go up and cause barotrauma. Whereas in a pressure control ventilation, what happens is your pressures are controlled, you can definitely avoid barotrauma, but the disadvantage is your tidal volumes are not guaranteed, and you can have a high tidal volume causing a volume trauma. So, which one to choose? Definitely, there is no significant difference between a volume cycle or a pressure controlled mode. You choose whichever is comfortable for you, but with the volume control mode, have a close eye on your pressures. If you're using a pressure control mode, have a close eye on your volume control, tidal volume. Set appropriate alarms and see to that the other variable doesn't go beyond your limit. This was the thing, and we still use these two modes. But there was an interesting study in the recent times which showed an early application of a mode called as airway pressure release ventilation, or APRV, which has a significant increase in the number of ventilator-free days and significant improvement in ventilation, respiratory compliance, extubation success, ICU and hospital length of stay with the use of early APRV compared to the normal ventilation. But still, there was no difference in mortality. APRV is one newer mode of mode in the ventilator. There are a lot of types of ventilators, and different brands of ventilator have different newer modes, and they try to advocate it to us, saying that it is useful in the ARDS and in other diseases. But we need to be very careful in choosing them. To buy a ventilator just for this APRV mode, I'm not very sure whether that is correct. But if you have a ventilator with the APRV mode, based on this study, you can definitely use that mode. But you need to be comfortable and you need to know more about that mode. That mode, as we all know, compared to the pressure or volume control mode in the APRV, what happens is we ventilate the patients at two levels, at a lower level and a higher level. This ventilation at a higher level and a lower level can be managed with settings of time and pressure. What is the low pressure that we set? What is the high pressure that we set? What is the time duration for which the high pressure has to be maintained and the low pressure has to be maintained? This is your mean airway pressure or the peak, what we call as the nasal pressure that is there in the alveolus. And even in the higher level or the lower level, patient can have their spontaneous. This is the most important advantage that we have in this mode of ventilation. The patient can breathe with spontaneously in both the phases of their ventilation, and this causes increase in the weaning process, increase in the level of taking them out of the ventilator, and decreases the length of stay and length of ventilation, as well as the amount of diaphragmatic injury that is caused by a controlled ventilation can be reduced. So these are the advantages of this APRV mode. I'm not for this APRV mode as a whole, but if at all you have this mode, you can definitely try it. You have good evidence for ARDS. So next comes the tidal volume and the pressure. So as we saw earlier, polytrauma and barotrauma are two important factors that we need to avoid in ARDS. This was the most important practice-changing study that came in 2000 in the Anaesthesia journal. This was done by a ARDS network, ARDS net study, and what this study did was they compared in patients with acute lung injury ventilation with a smaller tidal volume, which was 6 ml per kg, and they maintained the plateau pressure less than 30, and they compared it with the traditional tidal volume. And during the periods of 1990s and 2000, as we all know, even in anesthesia, we are using a high tidal volumes like 10 to 12 ml per kg for all the patients. So that traditional tidal volumes of 12 ml per kg, and they accepted a plateau pressure of less than 50 in those patients, and they compared these two patients as a whole. What it was found is there was a decreased mortality, increased number of ventilator-free days, and a decreased extrapulmonary organ. This changed the practice as a whole, and it was the most important. If at all there is one study that you need to know in ARDS, it is this study. This is the practice that we follow till now, and there is a definite increase in the survival and definite increase in the discharge date and rate. So it is advocated after this study that we need to use a low tidal volume. As we know earlier, tidal volume is a result of the pressure. Whether this improvement or whether this advantage that we had with the low tidal volume is just because of the low plateau pressure. This was a big discussion that was going on after this study, that the plateau pressure of less than 30, which was maintained with the tidal volume, was the most important factor for the mortality benefit. But later in the reanalysis of the ARDS net study, what they proved at different level of plateau pressures, maybe that is a 20, 25, 30, and 35, at different levels of plateau pressure, they compared the two tidal volumes and found that in each levels of the plateau pressure, the mortality benefit was definitely better with the lower tidal volume when compared to the higher tidal volume. So they clearly disprove that it is not only the plateau pressure target which is important, but independently low tidal volume of 6 ml per kg is a factor that can reduce the mortality and increase the survival rate and discharge rate in a patient with ARDS. maybe along with the blood pressure of less than 30. So if the low tidal volume is good, how low is it? Should it be whether 6, 4, or 2? That study was continuously monitored, and with the 6 cc per kg, 6 ml per kg of tidal volume, it was clearly shown that the mortality was very much low. And when they tried to further reduce the tidal volume and for the mortality benefit, what they found was it was showing an increasing trend in mortality. So the final verdict was 6 ml per kg was chosen as the optimal tidal volume for ARDS ventilation. So how do we do it? It is not based on the ideal body weight or the measured body weight of the patient. It is based on the predicted body weight. We need to use these formulas for a male or a female. It is predominantly based on the height of the patient. It is easy to measure the height of the patient in ICU and use these formulas to get a predicted body weight. Based on the predicted body weight, we set the initial tidal volume to 6 ml per kg of predicted volume. Set the initial ventilator rate to around 30 or 32 to match the baseline minute ventilation, because once you come down on the respiratory rate, what happens is your minute ventilation goes down. Minute ventilation is nothing but the product of your tidal volume and respiratory rate. So when the minute ventilation goes down, obviously your carbon dioxide washout will not be good, and patient can end up with a type 2 respiratory failure and an increased carbon dioxide level. So to prevent that, what we do is we go upon the respiratory rate and to maintain the minute ventilation. So subsequent tidal volume adjustment will be based on your plateau pressure. See the plateau pressure. Well, if plateau pressure is less than 30 and your CO2 is good, do not change it. Continue with the 6 ml per kg of tidal volume. If at all your plateau pressure is more than 30, definitely you need to come down on that. So if your carbon dioxide permits, you slowly come down on the tidal volume from 6 to 5 ml per kg and then to 4 ml per kg, but keep a close watch on your minute ventilation as well, and try to bring the plateau pressure less than 30. This is how we usually do it. And if at all your carbon dioxide goes up and if your plateau pressure remains less than 30, you can go up on the tidal volume to up to 8 ml per kg. So based on your carbon dioxide and your minute ventilation and your plateau pressure, you switch between 4 to 8 ml per kg of tidal volume. 6 ml per kg would be ideal. So definitely at the end of this part, we can clearly prove that lung protective ventilation is definitely a winner. Low tidal volume of 6 to 8 ml per kg is what we advocate, and limit the plateau pressure at any extent to less than 30 centimeters of water. Adjust the respiratory rate to have acceptable minute ventilation. Have a mild permissible hypercapnia. Don't try to keep the carbon dioxide level in a normal range of 30 to 40. Try to accept a permissive hypercapnia of almost up to 60 if your pH is more than 7.20. And these things of the lung protective ventilation after this ARDS study was extrapolated even to non-ARDS situation. Now in the ICU, for all the patients who get mechanically ventilated, we ventilate them only with 6 ml per kg, and I think even in anesthesia it is being practiced everywhere. So coming to the next important concept, PEEP. Why is PEEP important? We have dealt with the volley trauma and barrow trauma, and the next important complication is your attalec trauma. Attalec trauma is predominantly because of the repeated atelectasis or the collapse of the alveoli at the end of every expiration. We need to avoid that. Every time that the alveoli completely collapses, it is very difficult for us to open up the alveoli and keep it open. So what we do is we generate a positive end expiratory pressure. Every patient who is on a ventilator needs a PEEP, and then more so over in every patient who has a ARDS needs it. Definitely it is important. The goal is to maximize the alveolar recruitment and prevent cycles of recruitment and de-recruitment. Every time it completely collapses and opens up, it again causes more and more of attalec trauma and biotrauma. It can increase the inflammatory cascade. So that has to be prevented with the usage of PEEP. But PEEP as such definitely has some amount of side effects. It can cause an increase in your airway pressure, can increase the dead space volume. It can increase the intrathoracic pressure, and thereby it can decrease the amount of venous return or their preload. What happens in the venous return decreases or the preload decreases, you can have a hypotension. So barotrauma is also very common with the PEEP. So all these things has to be kept in mind, and you need to adjust your PEEP. So what PEEP is required? High or a low PEEP. For all patients on ventilator, we keep PEEP around 4 to 5. But whether in ARDS, we need to keep a high PEEP, that is around 10 to 15. What does the evidences say? This was the ARDS net study that we were talking about earlier. What they used in the ARDS net study, they were using a formula derived titration of PEEP based on the FiO2. More and more the FiO2 required to maintain a saturation of more than 90, they started choosing more PEEP. So based on this table, approximately to say, if FiO2 is around 80, you keep a PEEP of 60. It is 0.2 into the FiO2. If the FiO2 required is 70, you keep a PEEP of 40. If the FiO2 is 90, you keep a PEEP of 18, and maximum of 20 if the FiO2 requirement is 100. This is what is being initially chosen and used in the ARDS net study. This formula related titration of PEEP was used, and what they found was oxygenation was definitely better with the high PEEP. That is, along with the lung protective ventilation of a low tidal volume and maintenance of plateau pressure less than 30, if you keep a high PEEP, definitely oxygenation was better. But what was found is there was no difference in the survival and no difference in the discharge rate between the lower and higher. So what they said, PEEP need not be used in all the patients, but in case if you have oxygenation, major oxygenation problem, try to go upon the PEEP to manage the oxygenation issues. So how do we select the PEEP and how much PEEP to select? We again come to this pressure volume curve. This is your stresses on the pressure volume curve that we were talking about earlier. As you can see, initially during inspiration, for the amount of pressure that is being generated, the tidal volume slowly goes up. It reaches a certain point where it suddenly increases exponentially for the same amount of pressure change. As you can imagine in a balloon, once you start inflating a balloon, initially for the few minutes or the initial few parts of expansion, you need to generate more pressure to open up the balloon. And once it reaches a certain stage, even with a small amount of blowing of air, the balloon distance very well. And it also reaches a certain stage, after which if you keep blowing the balloon, it bursts. That happens again with the lung also. It reaches a certain point where it again starts plateauing. It means that if you further increase the pressure in the lung, it can cause over distension and barotrauma. So these part in the inspiratory part of your pressure volume curve is very, very important. This lower limit is the point where you need to keep your PEEP, and this is the point which is called as the lower inflection point, where the compliance of the lung starts improving exponentially, and this is called as the upper inflection point, which where the lung starts over distending beyond this point. So what we need to do is we need to ventilate the patient in between these 2 points. That is your upper inflection and your lower inflection point. And this point is very important to maintain your PEEP. Try to keep the PEEP above this point. If you keep the PEEP below this point, there are a lot of lung segments which are collapsed. This is the point where the lung starts opening up. All the collapsed alveoli starts opening up. So here, most of the lung parts are opened up, and here most of the lung parts are closed. So we need to keep the lungs with the part where the most of the lung points are opened up. So always try to maintain the PEEP above the lower inflection point. So how do we identify that? Whether it is easy for us to identify with the ventilator, there are some ventilators which come with this pressure volume curve. They do a quasi-static pressure volume curve measurement. With individual pressures, they try to monitor the complaints of the lungs, and they give a graph like this. And this was compared with the study with the CT, and they found that as the curve increases, the amount of lung that was collapsed improved predominantly, and it reached 100%. So is it easy for us to identify this lower inflection points? Definitely not. Even if ventilator gives you this graph, only 25 to 50% will have an identifiable inflection point. Other waveforms will predominantly be like this. It is very difficult for you to identify the point of lower inflection. So for us to keep the peak above that lower inflection. So based on the AIDS net approach, you keep the peak based on your FiO2 requirement, but that again has a lot of problems because as we know, AIDS is a heterogeneous lung. There is a significant recruitable lung volume. Your PEEP will definitely open up alveoli and benefit the patient. But there are also very large amount of non-recruitable lung volume which can get hyperinflated and it can harm the patient. So identification of a potentially recruitable ARDS lung becomes important for us to keep PEEP. So how do you identify that? They tried it with doing CT in multiple patients. It is always very difficult to shift the patients with ARDS to CT just for study purpose. They studied a lot of patients with ARDS and they found that the percentage of recruitable lung varied significantly with lot of patients, and predominant of them had a very low amount of recruitable lung. So studies came up comparing the high PEEP and the low PEEP, and this large study showed there was no statistically significant difference in mortality between a high PEEP and a low PEEP. So it was very difficult for us to decide on what PEEP to keep. Then came the concept of driving pressure. As we saw earlier, this is your pressure time scalar. This is the maximum peak pressure that we attain at any inspiration. And once you give the pause, what is measured is your plateau pressure. And this is the driving pressure that we are going to talk about. This is the difference between your plateau and peak. This is very, very important. And based on this study in 2015, they found out that this driving pressure, when maintained in a low number, can cause an increase in the oxygenation as well as sunlight. So based on this study, what they found is when you increase on the PEEP, your driving pressure will increase and your plateau pressure will increase. But if the driving pressure does not increase, that is, this driving pressure remains the same, even if you increase the PEEP, it means that this lung is more recruitable and they can have a favorable effect on your PEEP. But on the contrary, if increasing your PEEP gradually increases your driving pressure, your mortality is going to be high. And in those patients, the recruitability is very less. Usage of PEEP in those patients was less. So what is the driving pressure that we can aim? In the same study, it was found out that the driving pressure of around 16 showed an improvement in the mortality. So what we maintain is you maintain a PEEP and see to that the plateau pressure above the PEEP, that is your driving pressure, does not cross 16 centimeters of water. So based on this, we can titrate your PEEP. This is your pressure time scalar. This is your PEEP. This is your plateau pressure. This is your peak pressure. This is your driving pressure. What you do? Increase your PEEP from 5 to 10. Increasing your PEEP from 5 to 10. If it does not increase your driving pressure or your delta P, see, as in this, your delta P actually comes down and your plateau pressure is maintained. This PEEP is good. It has recruitable lung. So in these patients, you can keep a high. But when from this point, you again increase the PEEP from 10 to 15. If it causes an increase in delta pressure and an increase in plateau pressure, it means you are overinflating the lung. So in these patients, it is better not to increase the PEEP. So from 5 to 10, from 10 to 15, these things happen. Definitely 10 is a good PEEP, but 15 is not a good PEEP. You keep PEEP somewhere in between 10 to 15. See your oxygenation improvement, and based on that, you can maintain the PEEP at that level. So it is PEEP is initiated based on oxygenation level as per AIDS net protocol, and it is titrated based on the compliance of the lung. and note effect on the driving pressure with the change of PEEP. Titrate PEEP to get the lowest driving pressure, that is somewhere around 16 centimeters of water. So as a conclusion, whether you need to keep PEEP or not, there is currently no evidence that a high PEEP strategy is beneficial when applied to unselected ARDS patients. That is patients in whom you know whether lung is recruitable or not. And anatomical recruitment with PEEP is very variable. So high PEEP may be justified in some subgroups. There is no easy clinical way to identify a PEEP responder. See for improvement in saturation. If increase in PEEP causes an inadvertent increase in plateau pressure, definitely it is bad. Drop in tidal volume, it indicates over restriction. So based on that, you can adjust. So these are the basic lung ventilation strategies that we use: low tidal volume, with a high PEEP and a plateau pressure that is maintained less than 30 centimeters of water. Ideally, this patient should improve with this amount of lung treatment maneuvers. If they are not improving, then we have to go for what is called as a rescue or salvage measures for refractory hypoxemia. What we have for that is inverse ratio ventilation, recruitment, early proning, and ECMO. Out of what are the evidence that we have for this, we just discussed. First is the inverse ratio ventilation. As we all know, we set up some amount of IE ratio. We give some time for the patient to have inspiration, some time for the patient to have expiration. We all know that expiration is a passive process. It needs more time when compared to inspiration. Once you start coming down on the expiratory time, what happens is that alveoli doesn't empty completely. It starts accumulating more and more amount of air at the end of expiration, and it can cause autopsy. So always what we keep is IE ratio of around 1:2.5 or 1:3 to maintain adequate expiratory time to remove the carbon dioxide completely. But what happens in ARDS or in patients who have a complex problem or oxygenation problem, what was tried was they started increasing the inspiratory time. They gave more and more time for the inspiration, more and more time for the collapsed alveoli to be opened, or the alveoli more and more, to have more alveoli taking part in the oxygenation process. So that was tried, and what they did, they prolonged the inspiratory time. It sometimes improved the oxygenation by allowing regions of lung that require more time to open, that is your slow alveoli. When the inspiratory time surpasses the expiratory time, that is 1:3, it becomes 1:2. Then we come to 1:1. Inverse ratio means it inverses. That is, we give a ratio of 2:1 or 1.5:1. That was studied in multiple studies, and despite improvements in oxygenation, it did not show improvement in meaningful outcomes of ARDS. So definitely inverse ratio ventilation is not recommended, but you can have some amount of decrease in your expiratory time to increase, give more time. What we use is somewhere around 1:1.8 to 1:2 or 1:1.5, but definitely not an inverse ratio ventilation. Next concept is recruitment. What is recruitment? Recruitment is the opposite of collapse. Once the lung completely collapses, you need to open up the lung. So the aeration of unaerated lung units to take part in the gas exchange is called a recruitment, and it causes opening of collapsed alveoli or drives out the edema fluid. This is a process, and for that, what we do is a maneuver called recruitment maneuver. This is intermittent brief application of a high transpulmonary pressure to open up these unaerated lungs. What we give is a increase in your transpulmonary pressure. It can be done with multiple ways. Some of the ways that we early do was what is called as 30-30 or 40-40 or 50-50. They give a high pressure of 30 centimeters of water for 30 seconds, 40 centimeters of water for 40 seconds. This can be given in some ventilators as a sigh breaths. You just press the sigh button. It gives intermittent high pressures for a fixed period of time. Next comes what is called as a peak pressure plus PEEP way, in which you slowly go up on the peak pressure or the plateau pressure or the pressure control. What we try to aim is we slowly increase the transpulmonary pressure to a certain extent. Initially it was 20, from 25, 30, 35, 40, 45, you go up to almost 60 centimeters of water, keep it for some time, then slowly come down on the total pressure. This can also be right. But what is found is there was an inconsistent effect on oxygenation. It was variable depending on the magnitude and direction of effect, and the duration of benefit also was very, very variable. It was only very transient. And the response affected by etiology, lung compliance, prior tidal volume and peak, duration of ARDS, and the type of maneuver that you use. And it was also found that it is almost equivalent to PEEP alone. Whether you give a PEEP alone or you do a recruitment maneuver with the PEEP, the difference is not going to be a major one. So how much to inflate it? Based on the different things, you can inflate it up to 60 centimeters of water. So even though there was not much benefit, many people used to do this recruitment maneuvers for a long period of time. The final bell was rung in 2016, 2014, in this large trial called ART trial, where they found out that the mortality was increased with the lung recruitment at a titrated PEEP strategy. So definitely in patients with moderate to severe ARDS, a strategy with lung improvement, lung recruitment compared with low PEEP increase the all-cause mortality. This recruitment should not be routinely done. So what we say is evidence are heading towards harm, probably not better than PEEP alone. Inadequate evidence for its efficacy. There is a transient increase in oxygenation, can be used as a salvage measure during severe hypoxic episode when you get the patient ready for a proning or a ECMO, but not as a routine measure. Keep a close watch on BP. People can have a decrease in the preload and they can go in for hypotension. And whenever you do a recruitment, set appropriate PEEP at the end of recruitment. Otherwise, your recruitment will not be useful. Next comes the most important part. As Dr. Ayyappan said earlier, prone positioning is no longer a salvage measure. It is almost taken and brought it as a state of the art or the standard protocol for any ARDS measures. This is one maneuver that has shown very good benefit in ARDS patients. Can be done in almost all the setups and for many patients. The basic physiology in this thing is, in supine position, what happens? Your heart is there. It will compress the dorsal portion of the lung. As you all know, ARDS, the problematic part is your dorsal lung. And this problematic dorsal lung part has further worsening because of the weight of the heart pushing on the part of the lung. And the diaphragm position and the amount of pressure from the abdomen also is increased in the supine position. And there is expansion of the chest wall again is not very homogeneous. Anterior wall of the chest moves better than the posterior wall of the chest, but the problem is in the posterior lung part. So again, that is going to cause a problem. So what we do in prone position, heart goes down, the pressure is relieved from the weight of the heart. The pressure of the diaphragm and the abdominal organs, the abdominal pressure to a certain extent comes down, and the chest wall compliance becomes more homogeneous. The posterior part comes up, and that part of the chest wall is free of any pressure, and it can move better and cause more and more ventilation of the affected part. This again causes an improvement. Also, the transpulmonary pressure, the amount of pressure change between the anterior and the posterior part of the lungs was very, very high in the supine position, becomes less in prone position, and the amount of blood going to the lung that is more ventilated is going to be high. So all these things were evidently proven in this study in 2013 called as ProSaver study. It showed a clear-cut improvement in mortality, and what is very important is to know that it is proven in severe ARDS early application. That is, it's tried within 7 days or 14 days, but it should not be tried the patient in late ARDS and prolonged prone position. Patient should be in prone position for at least 16 hours in a day. Proning for 2 to 3 hours will not help you. It should be done in the early phase of ARDS, in moderate to severe ARDS, and for prolonged prone positioning. It can significantly reduce the mortality either in 28 days or 90 days. There are a lot of contraindications. They didn't want to go into prone ventilation. So what is the conclusion? Consider it in refractory hypoxia, in severe ARDS, Manpower definitely is necessary. You have to take care of it. Do in early stage of ARDS, prolonged duration every day, turn supine every day to look for complications and give care and watch for complications closely. This is one thing that we can advocate definitely. Next comes the ECMO. ECMO, as we all know, it has become a fashion statement after putting our past CM in ECMO. People started asking for ECMO when they come for even for a liver failure to ICU. They started asking whether you have ECMO in your ICU. So ECMO has definitely become a fashion statement, and people are more and more aware of its usage. And in the ARDS is one part where ECMO was used extensively. It is extracorporeal support used to oxygenate the blood. Definitely, it needs a center which is well equipped with the machine, as well as people who are trained in ECMO management. What is the evidence that we have? Initial trial was called as a Caesar trial. This was showing a definite improvement in mortality in patients in whom ECMO was used. P-value was almost less than 0.01, and it was showing an improvement in the mortality. So initial, after the study came, almost everyone were jumping to say that ECMO was is the magic bullet for ARDS management. But later, this study was further analyzed, and it was found that it was the difference between a hospital where ECMO was not used and in a hospital which was equipped with ECMO usage, and not between patients who are not on ECMO. Because in ECMO group, only 76% of the patient had ECMO actually. Remaining 25% improved with the normal ARDS management. This again states that ECMO hospital or the hospital which was equipped with ECMO was more experienced or more equipped to manage a respiratory failure or an ARDS, and the care that they gave as a whole for ARDS was better in that group, and that was actually the reason for the improvement in mortality. Caesar study still supports ECMO as a valid treatment option for the management of patients with severe respiratory failure. However, it does not show that ECMO is better than conventional ventilation. This study does highlight the importance of involving specialist units, effective lung protective ventilation, and ECMO as an option in refractory respiratory failure. So then came the most important study, all-year study. This was a more properly done study, and all the patients in ECMO group had ECMO, and this didn't show a significant improvement in mortality. And at the end of the study, it was clearly shown that ECMO has benefits which are not clear. It can be considered in refractory hypoxia, not responding to prone ventilation in early ARDS, and has severe complications. It needs expertise to use it. Next comes the neuromuscular blockage usages in ARDS. As we all know, ARDS is the oxygenation problem. Most of the patients in ARDS, we tend to use neuromuscular blockage, but still there was a study called Accurus study which showed a mortality benefit in usage of relaxant, which was a surprise for many of them. They used cisapractidine for the first 48 hours of ventilating these patients, which was disproven in the following trial called as a Rose trial, which was not associated with any mortality benefit. The other thing that can be used in ARDS is the high frequency oscillatory ventilation. It was predominantly used in pediatric patients, and it was extrapolated and used in many adult patients as well. As we all know, it uses ventilation with a high frequency and a low tidal volume. Thereby, the theoretical advantages can have a high mean airway pressure. It provides PEEP effect, prevents collapse, and limits over distension. Whether this was all obtained in the practical view, in the Oscar and the Oscillate trial that we had on this HFOV in ARDS, it was clearly proven in the Oscar trial that there was no major advantage. But what happened in the Oscillate trial is there was more mortality with the usage of HFOV when compared with the normal patient. This brings us to the thing that HFOV is not recommended for ARDS. It can be dangerous. Next, if patient has a dysynchrony because of double triggering, ineffective triggering, or flow synchrony, please try to do it. So putting it all together, whatever evidence-based and the practices that we know, treat the cause, that is most important. Other supportive routine ICU managements are also important. Mode doesn't matter, volume or pressure control. Calculate patient's predicted body weight. Set the tidal volume as 6 ml per kg. Set your respiratory rate for the adequate minute ventilation. Maintain the plateau pressure less than 30 and set FiO2 on team to obtain a saturation goal of more than 88%. If still hypoxic, rescue measures, recruitment not much useful, inverse ratio ventilation, be very careful. Two things that you can definitely use is early proning and ECMO. HFOV do not use, and neuromuscular blockade, if at all using, use it in the first 48 hours. These are all the ventilatory management. Coming to the non-ventilatory management of ARDS, one of the most important study was the fluid related study, which compared the conservative and liberal strategy. They use CVP or the pulmonary artery pressure to monitor. What they proved is in a group where cumulative fluid balance was maintained, either euvolemic or a slightly negative balance, the mortality was less and the ventilator free days and the ICU free days were more. So what we suggest is do not push in more fluids for these patients, even if they have hypotension. Try to use early vasopressors and try to come down on the fluids. Next important thing is your steroids. A lot of questions everywhere about ARDS, especially after this COVID. Steroid usages are advocated for ARDS as a whole. But before COVID era, steroids usage, multiple studies were done, and almost all the studies showed either a mild improvement or equivalent to not using it. But this one study done by Meduri showed a very good improvement with the steroid, and it was a well planned study. And based on this Meduri trial, what was recommended was it can be used early in the disease course, that is within 14 days of onset, if the patient has persistent or refractory moderate to severe ARDS, despite initial management with standard therapies. Prolonged course has to be given with slow tapering. Drug of choice is methylprednisolone and beware of the side effects. So what dose you use based on this study, Meduri trial, loading dose we give 1 mg per kg. The first 14 days, 1 mg per kg per day. From day 15 to 21, 0.5 mg per kg per day. 22 to 25, 0.25 mg per kg per day. And from 26 to 28, you come down to further less and stop. So this slow and prolonged course of tapering is important in these patients. Inhaled nitric oxide, it was tried, but definitely this time we may say no to this nitric oxide. There is definitely no benefit. So as we can summarize, whenever you put a patient on ventilator, if a confirmation of ARDS is done, always maintain a tidal volume of 6 ml per kg, plateau pressure of less than 30, PEEP of more than 5, but determine it based on the compliance. Check for hypercapnia, higher level of PEEP if oxygenation is still less. Go for a neuromuscular blockade and prone positioning, and if still nothing is improving, then you can try your ECMO. This is the most practical form of way in which you can treat the ARDS. These are some of the landmark trials in ARDS. These are the trials that I based my talk on. You can go through it when you have time. Thank you. So I see you. Thank you, sir. I think thank you for the opportunity again. You can take it.
Thank you, sir. Thank you for the excellent lecture on the ARDS ventilator management. We have some queries, sir. One is neuromuscular blocking agents in ARDS ventilation. How useful they are?
Yes, sir. As I said, it was a good study done in called as accuracy study, which showed there was an improvement in mortality. Mortality benefit is very, very difficult to attain in any studies, and whenever you have a mortality benefit, you give more importance for that study. And this is one study which showed that initial 48 hours of ventilation in a ARDS, when you use muscle relaxant, they definitely showed the improvement. But later another study came which showed that that amount of mortality benefit is definitely not there. But practically saying, any patients on ARDS with ARDS on ventilator will definitely be on a high PEEP on a high FiO2, and when they start having their spontaneous breath or when they start moving, what happens is they de-recruit very rapidly. So to prevent this de-recruitment, most of us continue them on the relaxant. It is better to continue them on relaxant at least till they come down on peak requirement. We ideally stop relaxant when the peak requirement comes below 10.
Sir, is there any role for IV interferon therapy in ARDS management?
No, sir. No definite role for it.
Actually, some questions you have already answered, like time frame for prone positioning, open lung concept and all. Can you just highlight something on permissive hypercapnia, which is a very important question for the MD postgraduates?
Yes, permissive hypercapnia, we accept some amount of hypercapnia. Usually, what we aim to achieve is any patient who is on ventilator, we try to achieve a CO2 in the normal range, that is around 30 to 45. But there are some places like this ARDS management in which you need to ventilate them with a lower tidal volume. And by reducing the tidal volume, what happens is your minute ventilation goes down, and obviously your carbon dioxide starts going up. But don't worry about the carbon dioxide. What is more important for us is ventilator-induced lung injury, which can be either a volley trauma or a barrel trauma. So we need to be more careful on preventing them rather than worrying about the carbon dioxide. So what is this stated is some amount of increase in carbon dioxide, that is maybe up to 60. Up to 60 of carbon dioxide can be accepted if your pH is good. If pH is very less, like 7 or 7.0 or 7.1, then you can have some amount of compensation with your tidal volume and try to bring down the carbon dioxide. But if your pH is definitely 7.2 or more, accept a carbon dioxide of around 60 and keep ventilating the patient with a lower tidal volume. That is what is called as permissive hypercapnia, and it is well validated in the ARDS.
Sir, one practical question. If we have to ambulate, if you have to transfer these patients with ARDS, for example, if we have to transfer them to the theater for some surgical management or shifting them to CT, what type of protocol we have to follow? Because disconnecting them from the ventilator and shifting them, is it
any procedure on a hypoxic patient, on a ARDS patient is definitely going to be risky, and we need to definitely weigh the risk and benefit of the procedure. If the risk is more and the benefit is less, definitely we need to avoid the procedure. But if the benefit is more, like if you need to do a CT to identify a extrapulmonary cause for ARDS, like a sepsis in some other place which needs to be addressed, you can definitely transport the patient, completely relax them, keep them on a high support. What we do is we use a transport ventilator for transport, put them on a transport ventilator with the same settings in which they were on the normal ventilator, and observe them for at least 15 minutes in the ICU, whether they have any decompensation. If they don't have a decompensation, then start shifting them. Immediately putting them on a transport ventilator and you take them out of ICU, on the way, the chances of them de-recruiting and decompensating is going to be very high. See if they are decompensating in the ICU. If the decompensation is very much, I think we need to even abandon the procedure. If at all we are transport with a good team, with people around, at least the doctor should be there around to take care of the patient and to monitor the pressures and saturation.
Thank you, sir. Thank you very much for enlightening us about almost all the parts of ventilatory management of ARDS. Edward, sir, do you have any questions, sir?
Sir, you are allowing a permissive hypercapnia. So the chance of respiratory center stimulation will be high. So there is a chance of asynchrony between the patient and the ventilator. In that case, the muscle paralysis will be more beneficial.
Yes, definitely. Most of the patients with ARDS, they are on muscle relaxant. Whether it is based on the study or not, in practical purpose, all the patients who are in the active phase of ARDS mostly will be on the relaxant.
So in that case of ventilatory asynchrony, we can go for muscle relaxant.
If there is a asynchrony, definitely you can go for muscle relaxant. And if your plateau pressure allows you, you can go up on your tidal volume up to 8.
Okay, sir. Thank you. Thank you, sir.
Okay, sir, we'll move on to the last session. about COVID ARDS by Dr. T. Sendil Kumar, who is a student of legend in anesthesia, Dr. Ravi Shankar sir, and he had done F&B critical care medicine. Right now, he is a senior consultant and in charge of medical ICU, Meenakshi Hospital, Tanjavur. We welcome Dr. Sendil. Can start with your presentation on COVID ARDS.
Thank you, sir. Thank you. Thank you for the organizing. Thank you the organizing team for giving me this opportunity. Am I audible?
Yes, sir. Yes, sir. You are audible.
Slides are visible, sir.
Yes, sir.
Yes. Okay. Directly, I'm going on to the topic. So, CARDS, which is nothing but COVID-19 ARDS, COVID-19 ARDS or COVID-associated ARDS. So we're going to see just a small overview how far it is different from the regular ARDS and how we're going to manage it. Okay. So going on to the definition of the COVID ARDS. First, the definition of the SARS-CoV should be in line with the definition of WHO. That is nothing but the symptoms with the positive RT-PCR or positive CT findings. And with COVID positive, if any equations in line with the definition of Berlin definition of ARDS, it is considered to be an COVID ARDS. So going on to the pathophysiology. So right from the beginning, the COVID is nothing but a single-stranded RNA virus which enters into the body with the help of a spike protein, which facilitates the attachment to the host cell via ACE2 receptors. So these receptors are abundant in epithelium, respiratory epithelium, and that is alveolar type 2 cells, and also in the vascular endothelium. These are this abundance of these receptors in these two types, that is vascular endothelium and respiratory epithelium, causing it to be a notorious and difficult to handle, difficult to manage the COVID ARDS. So because of this virus replication, there is an extensive tissue damage in the infected endothelium or epithelial cells. And this damage is caused due to a cascade of inflammatory and immune-mediated responses. Okay. Then, as usual, after the damage has happened in the alveolar epithelium, then there is an exudative, proliferative, and fibrotic phase, which is already dealt in detail, causing the ARDS progression. And what makes this COVID ARDS more dangerous is, before going to the COVID ARDS, so on ARDS, again to overview on it, so the ARDS could be due to either pulmonary or extrapulmonary cause. Pulmonary cause is mainly due to a direct alveolar damage, and extrapulmonary cause is to vascular endothelial damage and leaky capillaries, and more of an inflammatory process. So in COVID ARDS, both this, which is concomitant to the typical phase of ARDS, but what is making it more complicated is immune-mediated immune cell invasion and activation occurs in COVID ARDS, which causes both direct and indirect presentation, indirect pneumonia, that is direct alveolar damage and pulmonary inflammatory response. Both happens so rapidly and both overlaps considerably and causing it more difficult to handle the patient with COVID ARDS. So what it causes is immune cell invasion and activation, augmentation of massive inflammatory cascade will happen, cytokine flooding and cytokine induced immune dysfunction, and the main thing is impaired alveolar epithelial healing, which happens for a prolonged period of time, which making it difficult to treat the COVID ARDS patient. And all these things causes diffuse, along with the alveolar damage, there will be a vascular endothelial damage, and because of vascular endothelial damage, the most important is loss of hypoxic pulmonary vasoconstriction, that is redistribution of blood from hypoxic portion of the lung to the non-hypoxic portion, which is highly hampered, and formation of mycothrombi and pulmonary vascular occlusion. All these things leads to increase in both shunts and dead spaces. Hence, this vicious inflammation and hypoxia, which happens hand to hand at a very fast rate, leads to multi-organ dysfunction. More than ARDS, the multi-organ dysfunction, which is likely to be the cause of higher mortality in patients with COVID-19 pneumonia ARDS. So coming on to the phenotypes or clinical presentation. So as we know, there is a constellation of clinical presentation, right from simple cough and body pain to severe breathing difficulty. We go into the specific ARDS phenotypes. That is, In early phase of pneumonia, it is called type 1, which is due to near normal pulmonary. Here, the patient lungs will be of near normal pulmonary compliance with more aerated lung volume, and type 2 is decreased pulmonary compliance with less aerated lung volume. That is severe COVID-19 pneumonia. We'll see this in detail. So in early COVID-19 ARDS, that is COVID-19 pneumonia, here it is more likely to present like an pulmonary or direct ARDS, where it will be benefited from. And severe COVID-19 ARDS, which is more, is an overlap of extrapulmonary and pulmonary ARDS. Okay, so here it is a normal healthy lung, where after a COVID infection, viral injury, which causes a direct damage to the alveolar epithelium, and more of the aerated lung volume will be there. Here, during the early ARDS, the hypoxia is more likely due to a low VQ mismatch. But in severe ARDS, there will be a consolidation, collapse, and inflammatory response, which is more on a dependent portion of the lung, leading it to a increased lung weight, and there will be both increased ventilator perfusion mismatch and also shunts, which markedly happens and causing a severe COVID-19 pneumonia. Here there are, sorry. So here in this study was done showing that type 1, where they have done a CT and also calculated various parameters, and they found out that in type 1 the lung mass will be less, and the gas volume, that is aerated volume of the lung, will be more, and the respiratory compliance is more in type 1 type 1, that is the early phase of the COVID-19 pneumonia. But in late and severe phase, where the lung mass will be very high and the gas volume, that is aerated volume, will be very low, and respiratory compliance is also very low. Okay, so based on this, during the early type, the ventilator strategy will be different, and during the severe COVID ARDS, the ventilator strategy will be different. So coming on to the management of this. So before going on to the management, so even though there is a clear-cut, delineation of type 1 and type 2, but in clinical presentation, the clinical delineation of type 1, type 2 may not be that much easy. So most of the time when the cases are present to our critical care setup, the patient will be presented in the type 2 or severe COVID ARDS, where it is very difficult to handle at this time. So in the management of COVID pneumonia as such, if you see, the first is pre-infection, that is we need to vaccinate the patient, and also personal protection is important. During the incubation period, there is nothing much we can do. During viral replications, there will be some benefit may be happening with antivirals or immunomodulation. But in ARDS, during severe immune dysregulation, where there is a severe immune dysregulation, we have to target the immune modulation therapy only. So in type 1 patients, the PEEP level should be kept low to avoid, because the patient lung itself having a higher pulmonary compliance, to avoid any lung injury with interventions. And the tidal volume threshold should not be limited to 6 ml per kg, rather thereby preventing the collapse, passive collapse of the lungs. So respiratory rate should not be more, and the patient should, during this phase, most of the time, if we leave the patient with just oxygenation therapy, it will benefit more than rather intervening at this stage. So type 2 patient, that is severe ARDS patient, standard treatment for severe ARDS is in par with that of which has already been discussed, like lung protective ventilation, prone positioning, and relative high PEEP may be helpful in this patient. So we now, in this era of COVID, we are encountering the patients more in severe stages only, that is type 2 only. So going on to the other therapy, so here antiviral therapy, which initially showed that there is a reduction in median recovery time, but recent trials shows that there is very little or no effect on hospitalized patient, and as indicated by no difference in overall mortality or initiation of ventilation or duration of hospital stay. steroids beneficial, but the time duration to when to start steroid and how long should the steroid be continued is not clear. The evidence is not clear, but it has to be individualized according to the patients. Like when you are receiving the patient, at what stage the patient is in. But the many studies have clearly shown that the role of steroid is beneficial when there is a high when the oxygenation therapy is required. And other thing on steroid is what steroids to start, whether to start at dexamethasone or hydrocortisone or methylprednisolone. But there is no clear evidence of benefit of one steroid anything, but steroids is beneficial. That is what the final outcome of all the evidences shows. Anticoagulants, still there is no clear evidence of anticoagulants. That formation of microthrombi, yes, it is causing a clear-cut damage to the lung. Hence, it has to be stopped. So anticoagulants has to be started for the patients who are on high oxygen, who requires high oxygen therapy in order to prevent the recurring of more and more physiological dead spaces. And antibiotics, if suspicion of superadded infection, hence it will be helpful. Immunomodulation therapy, no clear clinical benefit according to the latest COVACTA trial. Initially, anti-interleukin 6, that is tocilizumab, shows to be beneficial, has some mortality benefit, but later on it shows nothing much. Comparing to placebo trial, and still more studies are going on, like targeting a specific interferon, which is interferon 2 or interferon 3, which is signature for COVID ARDS, where interferon 2 and 3 levels are more high in these patients. So targeted interferon therapy is on research, still in the research stage. Whether these researchers will put some light on us for managing the ARDS. And fluid management, coming to fluid non-pharmacological therapy, fluid management, fluid restriction in ARDS improves pulmonary function and less ventilation days as it is been similar to that of regular ARDS management. ECMO and other organ supports also show some benefits in managing COVID ARDS. So to conclude, COVID ARDS, the syndrome of ARDS serves as an umbrella term, while COVID ARDS is a specific disease, but there is no disease-specific treatment for it. And treatment mostly is supportive, includes lung protective ventilation. So how long we should give lung protective ventilation? Until we control the inflammatory responses, that inflammatory response and cascades that causes which is the major causative factor for severe ARDS in COVID patients. And once the inflammatory response and cascade comes down, then only the lung healing will start. That is the alveolar epithelium, type 2 alveolar epithelium. It starts repopulating the lung and makes the lung integrity and starts the lung structural integrity. Until that, we have to give a supportive therapy, includes that lung protective ventilation, proning, positioning, restrictive fluid management, anticoagulants, and therapy for infectious complication. All these things has to continue. And multidisciplinary approach is much more helpful right from the initial phase and during the rehabilitative measures and thereafter. And long-term consequences like impaired weaning of oxygen therapy, IC acquired weakness, ventilatory damage, diaphragmatic interactions, and other neuromuscular disorder, or the far more and other consequences of other organ injuries and thromboembolic complications. And these are all the long-term consequences which causes more and more mortality, adding more and more mortality to the COVID patients. So how to control? At present, how to control the COVID is by either first and foremost is personal protection, vaccination, and rather than getting infected and treating it. Thank you.
Thank you, Sendil, for the short and sweet presentation on COVID ARDS. I have some few questions. Can you hear, Sendil?
Yes, sir. Yes, sir. Yes, sir.
So proning in COVID ARDS, how early it should be? Time frame? It should be like, is it like similar like routine ARDS, or is there any difference in COVID ARDS and proning?
So that's what here in COVID, there are two clinical, if the patient is presenting at the earlier stage where there is only a ground glass opacities there is no much of profound hypoxia. During that time, intervening the patient, like giving a positive pressure ventilation, what will happen is, by giving a positive pressure ventilation on a NIV and increasing the respiratory drive of the patient will cause self-inflicted lung injury or early lung injury due to stretching of the lung or giving high PEEP at that time is most deleterious. Considering the proning, during at this stage, awake proning, they say that there is some amount of benefit in reducing the ventilation perfusion mismatch, which is happening at the early stage of the ARDS. That is early stage of the COVID-19 pneumonia. When severe COVID ARDS, it is similar to the management like ARDS. It is, proning is a standard of care for managing the severe COVID ARDS.
Okay. So what is your take on high flow nasal cannulation in COVID ARDS? High flow nasal cannulation of therapy.
Sir, yes, sir. That high flow nasal cannulation, it is similar to NIV, but what is the benefit of high flow nasal cannulation is it causes less of a lung injury in the early stage of ARDS. But always we should have, like NIV, always we should have a vigilant monitoring of patients on HFNC, where they might go on for respiratory fatigue and easy deterioration. In spite of the saturation might be sometimes saturation might be deceiving us. The patient might maintaining a saturation of 90 or 92, but the respiratory drive and the respiratory effort, and easily the patient will get fatigued. Suddenly patient will collapse on that. So vigilant monitoring of HFNC will be should be there, but definitely the HFNC has a better tolerance comparing to other modes of ventilations, like comparing to NIV, and which is less traumatizing in early phase of, that is type 1 COVID pneumonias, and it will be helpful.
Will there be any difference in post-COVID ARDS sequelae, like in lung healing? Will it be different from our routine ARDS, or this COVID ARDS healing will be different? Post-COVID.
So the sequelae of the COVID ARDS, the sequelae, that is post-COVID sequelae, it is not only pertaining to the lungs. There are array of complications are happening. Okay, right from the neuromuscular damage, right from oxygenation dependency, and other, even the psychological damage is more in post-COVID patients. Rather, in pertaining to ARDS, it is like the acute fibrosis which is happening makes the lung very much difficult to handle than with other ARDS patients. But on the magnitude of inflammation, how far it is continuing beyond the resolution of resolution of symptoms, we don't know yet. So how far the inflammation is happening, the problems is still happening, will still happen.
Thank you, Dr. Sendil. Edward sir, do you have any questions, sir?
No, sir. We can conclude.
Okay, can you conclude the session here? I would like to thank all the presenters here, Dr. Ayyappan, Dr. Charan, and Dr. Sendil, for the excellent presentation on ARDS. Over to you, Edward sir, to conclude.
Thank you. With that, we come to the end of this session. Next week, there will be no online anesthesia classes because of the Tamil Nadu ISA State Conference of Madurai. We will meet on 24th. So I thank the Acrula and A1 Logics and also the Anaesthesia TV and the presenters of this session, Dr. Senthil, Dr. Charan, and Dr.
Ayyappan.
Also, I thank everyone. And I also thank Dr. Jay Prakash sir for wonderful coordination. Thank you. We will meet next 24th. Thank you. Thank you, Ananda.